It's 7:30, so it's about time for us to kick off our film reading session. Thank you all for joining me this evening. For those of you who haven't joined us before, just a very quick introduction. My name is Ian, and I'm a radiologist. I graduated from the RVC way back in 2004 and got my MRCVS imaging certificate in 2009. I went back to the RVC to do my residency between 2013 and 2016, and I got my European diploma in 2018. And these days, you can find me at London Veterinary Specialists, which is the only multidisciplinary referral hospital in central London. If you do have any imaging queries I can help you out with, if it's a radiograph that you'd like some help interpreting, or if you'd like a chat about a particularly challenging case that you have and you're wondering which imaging modality would be most useful, then feel free to give me a call at the clinic on this number or drop me a line via email at this address. So for quite a few months now, we've been trying to make these sessions as interactive as possible by using the Poll Everywhere software. So that gives you guys who are not going to get the chance to present this evening a chance to take part and vote. So I will be asking you some questions about the cases as this session moves on. If you would like to take part, then you need to log into pollev.com and enter my username, which is IanDavidJoni636, so not enough room for the Jones. And you should hopefully see some questions appear at appropriate times. So feel free to respond, and hopefully we can then discuss your responses and have a little bit of fun doing so. So as for all these sessions, we'll just go through an example before I open up the floor, and you guys can tell me what you thought about this month's cases. This is a case that we covered last month. It's a 9-year-old female neutered Chihuahua that presented with dyspnea. So the original case, there were 3 radiographs, but we'll just take a look at 2 of them this evening as the example. The first is a right lateral thoracic radiograph. Hopefully you guys can appreciate that the heart is way bigger than it should be here. And not only is the heart enlarged, we've also got some steepening of the caudal border of the cardiac silhouette. And that large heart and that enlarged left atrium, which is causing the steepening of the caudal border of the cardiac silhouette here, is causing dorsal displacement of the trachea. Given that we are very suspicious that this patient has a primary cardiac problem because of the cardiomegaly and the suspected left atrial enlargement, the next thing we need to do is to take a look at the pulmonary vasculature. So in this lateral radiograph, we can take a look at the cranial lobar vessels, which are just here. So we've got cranial lobar bronchus just here, and then we've got an artery and a bronchus and a vein. So veins are ventral in the lateral, veins are central in the DV and the VD radiographs. So artery, bronchus, vein. We can compare the size of that vein to the size of an adjacent rib. Certainly it doesn't look bigger than the adjacent rib, so no evidence of any pulmonary venous enlargement, at least in this lateral radiograph. So the next thing, now we think that this patient probably has a heart problem, and more specifically a left-sided heart problem, given this big left atrium, is to try and make a decision as to whether or not there's any evidence of heart failure. So we can start looking at the pulmonary parenchyma and thinking about what sort of changes we might expect to see if this patient was in left-sided failure. So we'd expect to see some evidence of pulmonary edema, and typically dogs that are in heart failure and have pulmonary edema, they have changes which usually represent an accumulation of infiltrate either in the interstitium or the alveolum, or the alveoli, or both, at the hilus and in the dorsocaudal thorax. So here, if we compare the radiopacity of the cranioventral thorax to the dorsocaudal thorax, certainly it looks way more radiopaque in the dorsocaudal thorax here relative to the cranioventral thorax. Now, we we can still just about see some of the underlying pulmonary structures through that increase in opacity. So we just about make out some of the vessels here. And I'm not convinced in this view, at least, that we can see any bronchograms. So I wouldn't go so far as to say that was an alveolar pattern consolidation, but certainly in this view, a heavy interstitial infiltrate. So there is some suspicion here that, as well as having a primary left-sided heart problem, that this patient is also in heart failure. So having looked at the heart, the pulmonary vasculature, and the pulmonary parenchyma, just need to have a scout around, make sure that there aren't any changes anywhere else. So it doesn't look like there's anything in the mediastinum here. And the extrathoracic structures in this view look reasonably unremarkable. So we can take agenda at the dorsoventral view. Now, in this view, the heart also looks enlarged, and having picked up what we suspect to be a left atrial enlargement in the right lateral view, we can take a look at the left atrium in this view and see if there are any changes that might be compatible with left atrial enlargement. And one of the things we can look for in this view is an increase in the angle of bronchial divergence. So this is the trachea here. We've got the main stem bronchi just coming off the termination of the trachea. And then the left atrium is going to sit about here. And if the left atrium gets big, it's going to push these main stem bronchi laterally. And that's going to increase the angle of bronchial divergence, result in this cowboy sign. So if this is the back of the cowboy and these are the cowboy's legs, and the left atrium is the horse that the cowboy is sitting on, then the horse has essentially got bigger, so the left atrium is bigger, and it's pushing the cowboy's legs apart. So that would be a cowboy sign. And I do think there is a little bit of an increase in the angle of bronchial divergence here, just a suggestion of the cowboy sign. Now, what this view does for us is tells us a little bit more about what's going on in that dorsocaudal thorax. So if we look caudally both on the left and on the right here, we can see that there are a couple of little air bronchograms here. So we can see these radiolucent, so gas-filled arborizing structures just extending towards the periphery of the thorax. So those are air bronchograms. Because we can see air bronchograms, that means that there must be infiltrate within the interstitium and the alveoli, and that means it's an alveolar pattern. If there are air bronchograms there, it has to be an alveolar pattern, and if it's an alveolar pattern, then it's consolidation. So there certainly is evidence of failure here. So the only other thing that is worth mentioning on this view is I think we're missing a rib, so only 12 ribs, but everything else looks okay. So our conclusions here would be that this patient has cardiomegaly, it has left atrial enlargement, and it has evidence of consolidation of the dorsocaudal lung, compatible with a left-sided heart problem. This patient, given its Chihuahua, most likely mitral valve disease, and secondary left-sided heart failure. So that was our example, and that was one that we covered last week. Let me just make sure that there's nothing else that I wanted to say about this one. I don't think there is. Certainly a case that you guys are going to see in first opinion practice. So having gone through the example, this is a good time for us to check if our voting software works. So for those of you who have logged into Poll Everywhere, hopefully you will now see a question appear which says, are there any questions about this example? So if those of you who are intending to use the voting software this evening can respond, then I will try and sync it up and hopefully it'll work. We've got a couple of responses. So let's sync it all up. All right, so 3 people responded, excellent. And everybody is happy. So good news. All right, so if there aren't any questions about this example, and if you guys are feeling a little bit shy, then you can ask questions via the chat. Then we'll move on to the next case. So the next case is case number 1. So this is our first case proper of the evening. It's an 11-year-old male neutered Labrador. It's presented to you as mildly dyspneic, particularly when he's lying down. So we've got a couple of radiographs to look at. We've got a right lateral thorax, we've got DV thorax, so just the two. So anybody like to have a crack at case number 1? Who is feeling like they've got a good handle on what might be going on in this case? And there's a whole bunch of you to choose from. Like I say, the more that you interact in these sessions, the more you're going to get out. So anybody fancy taking case number 1? And this isn't an exam, and this patient is not lying in front of you trying to expire, so there's absolutely no pressure whatsoever. This is just a bit of fun.
I don't mind doing this one, Ian.
Yeah, thank you, Meta. So,
yeah, I haven't prepared though. So
that's okay. That's all right.
So yeah, the only thing that, well, the big thing that is catching my attention in this right lateral view of the thorax is a bone opacity lesion in one of the sternebras. There you are.
Okay, yeah.
Which I think is actually in between two of them.
Yeah.
But that's definitely something abnormal. I'm not sure if you can see it on the DV though. I haven't.
So there's too much superposition on the DV first.
Yeah. Yeah, so you cannot really see it. Yeah, maybe the heart maybe a little bit more rounded, I would say. Okay. And then there's a bronchial pattern, but that was probably due to age, if I have to say something.
Yeah, no, I agree. He's quite elderly, this guy. I said he was 11.
Yeah, but I cannot see. I'm not sure about there is like maybe rounded structures around the carina.
Okay.
I'm not entirely sure whether it's something more metastatic in there, because my main differential of that lesion will be Purine-Rostosarc.
Okay. Yeah, no, I think certainly this does jump out.
Yeah.
In terms of any potential changes, particularly in the thorax. Yeah, I absolutely agree that this is abnormal. So we've picked up a bony lesion. So we then need to think about the sorts of radiographic changes that we're likely to see with an aggressive bony lesion versus a benign bony lesion. So one of the first things that I consider is, well, where is this lesion? Because if it's at a predilection site for a primary bone tumor, towards the knee and away from the elbow, if you're a dog and you're thinking about osteosarcoma, then that already makes me concerned that we might be looking at something sinister here. The other radiographic changes that are associated with aggressive bone disease are going to be things like irregular periosteal reaction, cortical disruption, lysis, and a long indistinct zone of transition. So those are all sorts of things that you're going to see typically with something like an osteosarcoma. So typically an osteosarc is going to be distal femur or proximal humerus. It's going to be in the metaphyseal region. It's going to have a very irregular exuberant periosteal reaction. There's going to be evidence of cortical destruction, lysis of the cortex. It's likely that you're going to see some lysis, and there's a couple of different forms of lysis. So if something like a bone cyst, you'd see a very clearly marginated area of lysis, and that would be called geographic lysis. If it's tending towards something more aggressive, then you're going to see like a moth-eaten lysis, which does what it says on the tin, looks like the bone is full of holes, or a permeative lysis. And a permeative lysis, it just sort of looks very sort of stickery, almost not really like a sponge, because that invites comparisons with normal trabecular bone pattern. But it just looks like the bone has been eaten away. You often see a lot of soft tissue swelling as well, although not always. And it's often very difficult to tell where the normal bone ends and the abnormal bone begins. So a long indistinct zone of transition. So this lesion here, it's affecting two bones, I suppose. So it's affecting the third and the fourth sternum. So if we're trying to classify it, then I suppose we can say it's polyostotic. It looks predominantly proliferative, so it looks like we've got an increase in opacity of the tissues that are between the third and the fourth sternum here, and it's mineralized. That aberrant tissue is going to be bony. It's going to be mineralized tissue because this thing it's more dense in the adjacent sternum and the adjacent ribs. It's got quite a clear zone of transition here, so we can tell where this lesion ends and where the normal sternum rib begins. And we're not really seeing any convincing evidence of periosteal reaction. In terms of lysis, there's certainly some effacement of the borders of the caudal margin of the third sternum and the cranial margin of the fourth sternum. But it's difficult to know whether that's not because we've got superimposition of this new aberrant bone over the top of it. And again, it could be that the margins look a little bit irregular, but it's a little bit of a stretch to say that there's evidence of lysis here. It's also not really a predilection site for anything sinister, although you can get osteosarcomas affecting sternum. It isn't a place where you'd normally expect to see a primary bone tumor. So I think this is probably benign, and I think it's just a bunch of aberrant bone just associated with the sternal cartilage there, and it's just because this is the name of the dog. But it does stand out, absolutely, and I can't say 100% that this isn't something that we should be worried about, but certainly for me, it wasn't ringing too many alarm bells. It is an abnormality, but for me, I think it's more likely to be just an age-related incidental variant rather than something to get too worried about. So what I'm going to do in just a second is to just draw your eye to where I think we should be paying more attention, but we'll just linger for a moment on the thorax. I absolutely agree that these bronchial walls look a little bit thickened, and there's definitely some tram lines and some donuts here, but again, as Mike said, that could just be an incidental age variance as an elderly dog, and a lot of older dogs and cats do tend to have a bronchointerstitial pattern because there's some thickening of the bronchial walls. There is a little bit of an increase in interstitial opacity in this dorsocaudal thorax, but this is kind of an expiratory film. The diaphragm is in a reasonably cranial position. There's not much of a gap between the caudal border and the cardiac silhouette and the diaphragmatic margin, so that could just be expiratory. I don't see a T tube here at the moment. There's a little bit of soft tissue just superimposed over the dorsal lumen of trachea here, which could represent a little bit of redundancy of the dorsal tracheal membrane. Heart looks okay, the vessels look okay. Nothing in the mediastinum here for us to get too concerned about. A little bit of pericardial fat, so we can see the ventral margin of the cardiac silhouette and the sternum, there's fat there. But nothing really to get too excited about. And that rings true for the DV as well. So reasonably happy with the pulmonary parenchyma and the other extra thoracic structures. But what I would like to draw your attention to is if we just cast our eye caudally and we start looking at the cranial abdomen. So we've got the caudal lobes here, and we've got the liver here, and we've got part of the small bowel, and the small bowel is way up here. So we wouldn't really expect all of that small bowel to be so dorsal. So the small bowel is usually in the middle of the abdomen, so small bowel should be here, but instead it's up here. Because we've got displacement of that small bowel in this lateral view, that should make us think, well, is there something going on down here that's pushing that small bowel dorsally? And I think there has to be, because there is a space occupying lesion here, because otherwise this small bowel wouldn't be pushed quite so far dorsal in the cranial abdomen. So there is something going on here. So I think in this patient there is an abdominal mass here. So this structure, whatever it is, it has to be real, and it has to be space occupying, because there has to be something that's pushing the bowel up there. You can't really see it in this DV view, but it's pretty convincing in this lateral view. So for me, there's something going on in this sort of mid to cranial abdomen, and it's this thing here. So what I'd like to do now, having just elaborated a little bit on what we think may or may not be going on here, is just to open up the floor again. And I can tell you that there is an abdominal mass in this dog, but what I'd like from you guys is to tell me what sort of mass you think it is. So main finding for me on those thoracic radiographs is the dorsal displacement of that small intestine, which means that there is a mass lesion in this patient's abdomen. Now, is it something that is contributing to its presenting clinical signs? It's dyspnea? Well, possibly not, but it looks pretty big this time, because those small intestines are really way up in that. Given that we know that there's an abdominal mass here, what do we think it is? Is it a twist-bound mass? It would probably be one of the more common masses that we see Could it be hepatic? Could it be intestinal? Could it be something else? So let's see what you guys think. So let's sum this up. Let's see where everybody is going with this. So I've got 5 participants. So vast majority think splenic, which I think is a good shout. And we've got 40 of you guys which think it could be something else. Okay. So that's good. So not quite split down the middle, but quite a split. So, and this is a bit of a sneaky question really, because the way that I've presented this case is there's going to be something going on in the lung and the thorax because this dog has presented it's just mildly dyspneic, particularly when he's lying down. But the reason I've included it is for 2 reasons really. So to remind us to always look at the edge of the film. So on the edge of the film here, there is this lesion, there's this structure here, and also to show you this lesion because it turned out to be spectacular. So this isn't a splenic lesion, and it's less likely to be a splenic lesion based on this radiograph because of its opacity. So if you compare the opacity of this mass lesion to the radiopacity of the liver, it's less radiopaque than the liver. Now, if this was a splenic mass or a hepatic mass or any sort of soft tissue mass, equivalent to the density of the spleen or the liver, then it should have an equivalent radiopacity to those organs. But it's a little bit lighter. In fact, it's about the same sort of radiopacity as the abdominal fat and the pericardial fat and the subcutaneous fat. So we could go so far as to say we're suspicious that this mass could be a big fatty mass because it has the equivalent radiopacity of fat on this radiograph. And if it is a big fatty mass, then it could be a giant intra-abdominal lipoma, which is the other reason why I included this case, because I wanted to show you guys what an intra-abdominal lipoma, a giant intra-abdominal lipoma, looks like on a CT. So this doggy had a CT. Now, the reason why we took the thoracic radiographs was actually to effectively do a MET check rather than to check for the presence of this mass. So I knew that this dog had an abdominal mass before it went and had these thoracic radiographs. So again, it's a little bit sneaky because we're doing it the wrong way around in terms of the way it's presented. But it's still a useful case because we can take a look at this CT. So for those of you who are not used to looking at CTs, let me just stop it there and I can just sort of tell you what we've got on the screen. So this is the liver here. This is the gallbladder. This is more liver. This is a bit of stomach here. This is a bit of spleen here. And these are just little loops of small bowel. So we'll just run it on. I'll just stop it there for a second. Let me stop it here. Okay, so now we're sort of mid-abdomen here, and we've got some kidneys and some more loops of small bowel, so that this is all the small bowel that we can see that was displaced dorsally. We've got a little bit of spleen, and then we start to see this thing. So this thing is the mass of fat that we could see on that thoracic radiograph. So I'll just run it on. And this thing is huge. It just goes on and on and on. So this dog's abdomen is pretty much 70% just fat, really. It goes all the way from the cranial abdomen right the way to the caudal abdomen to the point where even the bladder is being displaced by this thing. So we've got liver, stomach, starting to see some spleen, starting to get into GI, we've got small bowel, kidneys, then we've got mass. And this mass also has some unusual lobulated, streaky, hyper-attenuating structures throughout it. And if we looked at the pre-contrast, so something I didn't mention is this is a post-contrast sequence, which is why all of the abdominal organs look so bright, particularly the kidneys. On the pre-contrast, there are some little focal hyper-attenuating mineralized areas within these lobulated, streaky, hyper-attenuating structures that are throughout this mass. And it's huge. This is a giant intra-abdominal lipoma. And there's more of these little streaky, hyper-attenuating areas. And it goes on and on and on, right up to the caudal abdomen, where even the bladder is being squashed by this thing. So this is the bladder here. So yeah, this is a nice example of an intra-abdominal, a huge intra-abdominal lipoma. Now, it's a shame that I don't have any abdominal radiographs to show you guys, and I was kicking myself for not getting just a single right lateral abdomen in this dog before it went to theatre. But you can see the mass in that thoracic radiograph, and it does have it has a reduced opacity relative to the soft tissues around it, and equivalent to that of the fat. So it is possible to look at that radiograph and go, there is a mass there, and my suspicion is that that is a fatty mass. So one of my differentials is an intra-abdominal lipoma. And that's what it looked like. So this thing was absolutely giant. The working theory at the moment is the reason why this doggy was having problems breathing, particularly when he was lying down, is sort of carrying this giant intra-abdominal lipoma around. It was sort of pushing against his diaphragm and making it hard for him to breathe, particularly when he was lying down and trying to get some sleep. So this is huge, and just to give you an idea of perspective, that's just how giant it is. So that's B, it's also Jidlinton carrying this giant thing that her and Janet have just removed from this doggy, who I'm sure felt a lot better for having that taken out. So there we go. So that's case number 1. So giant intra-abdominal lipoma. So anybody have any questions about case number 1? If not, we can move on to case.
Yeah, I'm sorry, can I ask a question?
Yeah.
The soft tissue attenuating material within the mass.
Yes. Good question. Yes. So those were areas of necrosis.
Okay.
So something that is worth saying, is a good point from Nicoletta, is that the other differential here would be something like a liposarcoma, so something aggressive. And a lot of liposarcomas, they do have these hyper-attenuating streaky areas within them. So that was something that we considered. But this thing went for histopath, and these streaky areas just came back as areas of necrosis. So the idea and the theory being that this thing had just got so big that there were parts of it that had become devoid of a viable blood supply as it expanded and got bigger within the abdomen, and then became necrotic. So these bright areas here are all little areas of necrosis within this giant lipoma. So yeah, you don't see that many of them, and this was a pretty spectacular one. And like I say, I'm kicking myself for not taking an abdominal radiograph, because it would have been a beautiful example of a giant intra-abdominal lipoma on a radiograph. But you can see it on that thoracic radiograph, and you can see it beautifully on CT. So there we go. So number 1, giant intra-abdominal lipoma. So now for effectively something completely different. It's a 1-year-old female neutered domestic short-haired cat presented as vomiting. So again, really typical presentation for primary care practice. Young cat, it's vomiting. And you take some radiographs of it, and they look like this. So this is a right lateral, and we've got DV on the left lateral. Okay, so who fancies case number 2? And this is more common, I would say. It's a nice case. Certainly something that you're definitely going to see in practice, this one. So we had Maita do case number 1, so she's effectively off the hook. So any of you guys fancy, any other guys fancy, just taking us through case number 2. Just sharing your thoughts on what you think might be going on here. And again, this little pussycat has long since been treated and is absolutely fine, and nobody's keeping score here.
I don't mind having a go at this one.
Yeah, go for it.
So the thing that I'm drawn to, probably because of my preconceptions of a 1-year-old cat that's vomiting.
No, they're probably very good preconceptions.
This area of small bowel ventrally it's quite fun.
Yeah.
And I can see there's kind of pockets of gas within those kind of bunches of small bowel.
Yep.
Otherwise, kind of looking outwards more generally, this cat's got a medium-sized bladder. I can see there's feces in the colon. Yep. Kidneys look kind of small, and as I would expect, and the liver's just poking out from the costal arch. There's a little bit of gas in the stomach, but it doesn't look like an obstructive stomach to me.
Okay.
So yeah, looking at this, I would be worried about some corrugation of that small bowel ventrally.
Okay. Yeah. No, I think that's absolutely fair enough. Hopefully, all you guys can see that. So it does look like this bowel is sort of bunched up in the middle of the abdomen. That is our DV, and then we've got a left lateral as well. All right. So what I'm going to do now is I'm going to activate the next question to see what the feeling is in the room about what we should do next. And then we'll come back to these radiographs in a second. So what we're going to do, we're going to just take this cat to surgery now. Do we think that there is indeed a linear foreign body here and that needs to come out? Are we not entirely sure? Do we think that we need a bit more information? And do we think the best way to gather information is to do an abdominal ultrasound? Maybe we don't have an ultrasound scanner available, or maybe you guys are more confident interpreting radiographs than doing ultrasound. So let's just maybe sit on this cat for a bit and we'll take some more plain radiographs and we'll compare the two and see what they look like, and then we'll make a decision after that. Or maybe there's a couple of you guys out there that have tons of barium around and you're trying to use it up, and this is a good opportunity to do a contrast study. What do we think? All right, let's sync all this up and we can see how you guys are feeling about these radiographs. All right, so we've got 5 responses. So again, not quite split down the middle, but a vast majority of you have seen enough, and it's time to take this cat to theatre. And a fair proportion of you are thinking, yeah, I'm reasonably convinced, but I just want to pop the probe on this cat before we call the surgeon in. And honestly, I don't think either of those answers are incorrect. I think it would be reasonable to take this cat to theatre equally. It never hurts to pop the probe on just to confirm our suspicions. So I absolutely agree. I do think that this bowel looks a little bunched in the middle of the abdomen here. Now, one of the things that I really like to see before I start thinking about diagnosing an obstructive linear foreign body is evidence of plication of the small bowel. Now, when you get plication of the small bowel, you get little comma-shaped pockets of gas forming within the lumen of the small bowel that's bunched up around the linear foreign body. And even though this bowel looks pretty bunched up in the middle of the abdomen, it's pretty difficult to convincingly see evidence of plication here. I'm not convincingly seeing little comma-shaped areas of gas within the lumen. So I absolutely agree that it looks a little bit big and it certainly looks bunched, but we need to be really careful about not over-interpreting bunching of small bowel in the middle of the abdomen, because sometimes you get these big fat cats, and because they've got lots of intra-abdominal fat, all of the bowel is kind of squashed into the middle of the abdomen. And that can look like bunching, but it's completely normal for a big fat cat. Now, this isn't a big fat cat, as we can see, because there's not much subcutaneous fat. And I absolutely agree that in this cat, the distribution and the size of that small bowel does look abnormal, but I probably wouldn't go so far as to say that it's plicated. However, there are some other changes here that might help convince us that, you know what, that bunching of the small bowel in the middle of the abdomen is secondary to a linear foreign body. So if we look at the stomach in a bit more detail, and we just take a look at the opacity of the stomach, we can see that it's got gas in it, but there are these little stringy radiopaque structures. We can see that they're superimposed on the lumen of the gastric fundus, and there's a whole bunch of them just in the lumen of the gastric antrum moving towards the pylorus. And we've got a soft tissue opaque structure in the lumen of the gastric antrum near the pylorus that looks like it's associated with all of these radiopaque stringy structures that are sort of all over the stomach, really. And it looks like there could be similar material maybe within the colon too, but immediately you start to see all of this opaque stringy stuff that's in the stomach, and something stuck, well, not necessarily stuck at this stage, but something located in the lumen of the gastric antrum towards the pylorus. You start to worry about, is there something linear here, and particularly, is there something stuck at the level of the pylorus? So a lot of linear foreign bodies, they kind of get anchored at the pylorus, and then all of the linear stuff just sort of stretches through the pylorus into the duodenum, into the small bowel, and on and on and on until it starts causing problems like the plication that we already talked about, and sometimes even interceptions. So in the DV view, it's not really super helpful. We can still see this sort of stringy radiopaque stuff that's in the lumen of the stomach, and that is a bit of a worry. In cats, the pylorus is positioned closer to the midline than it is in dogs, so the pylorus is going to be about here, and we can't really see it because it's superimposed over the spine. And the bowel, again, we've got little pockets of gas, but it doesn't really get as far as the little comma shapes that I like to see if I'm going to be confident about diagnosing implication and a linear foreign body. This one can't get in there, but he's not quite there. Now, in the left lateral view, this is the view that it's super useful if you are trying to confidently identify a foreign structure that's stuck in the pylorus, because if you think about where the stomach is, so if you use your left arm as the stomach, then you drape it across your abdomen, then you've got your pylorus, which is here on the right, and you've got your gastric fundus, which is on the left. So if you're in left lateral recumbency, then all of the gas is going to be on the right, which is where your pylorus is. And that's really helpful if you're trying to diagnose a foreign body that's stuck in the gastric outflow, because the gas will all be surrounding the foreign body that's stuck in the pylorus. So here we've got this area, which is the gas that's in the pylorus, and we've got this sort of blob of soft tissue opaque, linear, stringy stuff that is just right where we'd expect the pylorus to be. And not only that, we've still got these linear, stringy structures extending from whatever this is, and having seen the position of this structure in this left lateral view, which is exactly where I'd expect the pylorus to be, and the fact that we have got some bunching of the small bowel in the mid-abdomen, which is a little bit bigger than we'd expect it to be, I'm now super concerned that this cat has got some sort of linear structure, multiple linear structures within the stomach, stuck in the pylorus, and a linear foreign body within the small bowel. Now, I don't think it would be unreasonable to take this cat to surgery just based on these radiographs. I think this cat is it's vomiting, so it has clinical signs compatible with a gastric outflow tract obstruction. It has radiographic signs compatible with a linear foreign body and a gastric outflow tract obstruction. So it would absolutely not be unreasonable to cut this cat based on these radiographs. We're not really seeing anything else to get too concerned about at the moment, so we don't see any evidence of a pneumoperitoneum. There's no evidence of a peritonitis, so the peritoneal serosal detail is actually pretty good. So at the moment, whatever this thing is, it doesn't look like it's caused any serious problems. So best get it out before it does start to cause some serious problems. We did stick the probe on this cat. I can show you what it looked like. So it looked like this. So ultrasound images, still ultrasound images are pretty tricky to interpret. So I did my best to sort of orient you guys in terms of what's going on here. So this is essentially a short axis view of the gastric fundus. So this is the stomach. This is the serosa here. So that's the edges of the stomach, and then the bit in the middle is the gastric lumen. And all of these hyperechoic structures that are occasionally shadowing here, those are all those linear opaque structures that we could see in the stomach on the radiographs. So if you guys are doing an ultrasound and you're suspicious that there's a foreign body in the stomach, that you're suspicious there might be a gastric outflow obstruction, and you see what could be foreign material in the stomach, the next thing that you need to do is to take a look at the pylorus. And this is what the pylorus looked like in this cat. So again, to try and orient you guys, this is the stomach here. So that's the wall of the stomach. So this is the gastric antrum. This is coming down. This is pylorus here, effectively, and then this is duodenum here. And then we've got this echoic linear structure that's extending from the lumen of the gastric antrum through the pylorus there and then into the duodenum. Okay, so again, that makes me super concerned. So there shouldn't really be anything stuck at the level of the pylorus. You shouldn't really see anything extending from the lumen of the gastric antrum through the pylorus into the duodenum. The fact that it is makes me think that whatever this stuff is, or all those linear structures we could see in the stomach, that's stuck here. That's anchored at the pylorus. And this is a linear foreign body that's extending through the pylorus into the small bowel. So this is now duodenum. So I'm just following this linear structure now from the pylorus down the duodenum, and now we're starting to see a little bit of plication. So this hyperechoic structure within the lumen of the duodenum. So this is now all duodenum. That's a bit of the wall of the duodenum. This is the lumen. That's another bit of wall of the duodenum. So this is the lumen, and this bright structure, this hyperechoic linear structure, that's the linear-form body within the lumen of the duodenum. So if we follow this wall, so the near wall of the duodenum, and we follow it from left to right, we can see that it's here, and then it's bunched up like that, and then it carries on, and it does the same thing in the far wall. So this is the duodenum. We follow it from left to right, it's here, and now it's a bit bunched up, and then it carries on. And the comma-shaped gas lucencies that I was talking about, that you can sometimes see on radiographs, it's gas filling this space. So this is the wall, it's bunched, it creates these little pockets, and that's where you get the little sort of comma-shaped areas of gases on radiographs in patients that have linear-form bodies. But that's how it looks on ultrasound. So that's plication. You see that, particularly if you've got a linear hyperechoic structure within the lumen. It's a linear-form body. It pretty much has to be anchored somewhere if you've got the plication. Otherwise, it wouldn't bunch up like that. That's a reason to take a patient to surgery without anything else that you're seeing in this count. And then this is more small bowel. So this is small bowel here, and it's coming round, and it just looks messy. We've got a bit of lumen here. This is the structure. There's a question mark as to whether or not this linear-form body is actually going through the wall of the small bowel here, because it doesn't really look like it's in the lumen anymore. It looks like it's passing through. It's all bunched up around. So that's a linear-form body. That's how it looked on the radiographs. That's how it looked on ultrasound, and that's how it looked in 3D. So this is an intraoperative picture taken during removal of the portion of the linear structures that were present within the stomach and the pylorus. So that's that big, massive stuff that we could see in the stomach. And it was best visualizing that in that left lateral view, so we could get gas around it, so it was much easier for us to see it. So yeah, that's how it looked. And speaking to B and Janet, who were the surgeons that took this out, this thing went on for ages. It was in the stomach, it went into the duodenum, it went into the jejunum, almost, I think, all the way down to the ileum and the ileocephalic junction. So it was a pain to try and remove, and I think this can require multiple enterotomies to get it all out. But it did come all out, and the cat did absolutely fine. So went home, and hopefully it isn't going to eat any more of wherever all this stuff is, hair bands and God knows. So yeah, nice job. So this was a young cat with really multiple linear foreign bodies. So there we go. Any questions about case number 2? That's a nice case. That's absolutely the sort of thing that you're going to see in primary care practice. Not always the easiest thing to diagnose, but hopefully we've picked up on a few radiographic and sonographic tips there to make it a bit easier for you guys. All right, so this is case number 3. Anyone have any questions about case number 2? If not, we'll move on to this 2-year-old female neutered ossicat that's been involved in an RTA. And then we need some willing participant to run us through.
I'm happy to have a go, Ian.
Yeah, go for it. So we've got, how many radiographs? I'll give you 3 radiographs for this one, yeah. So we've got a thoracic series, essentially.
So
right.
we do have 3 radiographic projection of a skeletally mature cat, right lateral, DV, and left lateral. On the lateral projection is visible a well-defined air-filled bullous-like structure, which is present just cranial to the carina at the level of the 3rd, 4th intercostal space. So the structure is well defined. It looks like defined by a sort of really thin sort of soft tissue rim, and it looks like potentially in contiguity and or superimposed to the trachea.
Yeah.
In both of the lateral view, the bronchial bifurcation, it looks to me a bit not really well visible, like a bit malposition. However, if we check on the DV projection, we can see the lobar bronchi, we can see diverging and going essentially caudally in a normal way, and we can see also the cranial lobar bronchi. There is as well a sort of wedge shape, increased opacity within the lung lobe, mainly distributed in the caudal aspect of the right cranial lung lobe, and potentially, which is a bit more subtle, in the dorsal aspect of the right caudal lung lobe. So potentially this, essentially I'm gonna think that probably the impact with the car was in the right side, potentially. Within the right lateral, we can see also the distal esophagus, which is quite air-filled, because we can see essentially the air within the esophagus is going to outline the dorsal and the ventral wall of the esophagus, which appear like a sort of soft tissue band that is going to the abdomen, passing through the diaphragmatic outline. Also, the stomach looks quite distended, and we can see some sort of soft tissue amorphous material within the pyloric region, which may be food essentially. I cannot really see any ribs fractured. They looks fine to me. And the other thing is there is on the right lateral, there is this sort of tubular radiolucency, which is just dorsal to the third and fourth sternebra. I'm not sure if it can be a sort of superimposition of the lungs or a sort of small amount of pneumothorax.
Okay.
The abdomen looks fine. I mean, the included part of the abdomen, there is good serosa details. We can see the spleen, and we can see in the cranioventral abdomen a sort of air-filled small intestinal loops. So my conclusion are there is this sort of gas-filled sort of bulla within the thorax. I will put as a first differential diagnosis tracheal avulsion with potential rupture of the tracheal rings and focal distension essentially of the tracheal mucosa. Distended esophagus, I think, is secondary to the dyspnea, and also the stomach is dilated because the cut is dyspnoic. The patchy sort of alveolar interstitial pattern, I think, is secondary to lung contusion due to the car impact, and potentially left side pneumothorax, early stage of pneumothorax. We can see on the right lateral the tubular structure. Yeah.
Yeah.
Yeah, potentially. Or the other option is essentially the superimposition of the opposite lung that essentially is.
Yeah, just sort of wrapping itself around the back.
Yeah.
Okay. Yeah. All right. Fabulous. So I have absolutely nothing to add. I thought that was almost a perfect description of what's going on with these radiographs. However, I am still going to open up the floor, and Nicoletta's talked about a lot of changes here. So what I want to ask you guys is which of these radiographic features that have been described so beautifully for us are you most concerned about? Because there's lots going on. There's stuff going on with the lungs, there's stuff going on with the trachea, there might be some stuff going on in the pleural space, there's a question mark about pneumothorax. Which radiographic feature that Nicoletta has described are you most concerned about? Because there's lots going on here. It's a tricky case. So let's just give you guys just a second to take another look at the radiographs of this, just a single radiograph I've given you to point to and respond. We'll see what you think. So not quite as many responses this time, but we'll take a look at them. All right, is this going to work? No, it's not. Ah, dear. So I was hoping to see some arrows on this screen, and the arrows I was hoping would be pointing at the structure here, which Nicoletta has beautifully described. So there is indeed this clearly modulated, round, gas-filled structure that is present just cranial to the carina, and it's superimposed on the trachea, and as we've already had described, it does look like there's some discontinuity of the walls of the trachea here, and that absolutely is pretty pathognomonic for a tracheal avulsion. Now, this isn't something that I'd ever seen before, so I'm super impressed that Nicoletta has nailed that to the wall. It's not something that I saw during my residency, and it isn't something that came up in the literature either. So I did a little bit of research, and there have actually been a couple of papers published just recently, so back in 2020 by Joffe and by White, describing this, and mostly focusing on the surgical treatment of tracheal avulsion, but it covers some of the typical radiographic features and describes the radiographic appearance of tracheal avulsion. So yeah, this unfortunate cat has during its RTA, it's had its neck, I think they get hyperextended, I think, and you get a very increased pressure in the tracheal lumen, and as a result of that, the tracheal lumen effectively sort of pops. So you get a normal trachea or tracheal wall, then sort of a pseudo trachea, which is just made up of like a thin sort of wobbly membrane, which is what we can see just here. So this is that kind of thin wobbly membrane of the pseudo trachea, and because that wall, which is almost like a diverticulum, is so thin, it tends to sort of flap around, and because of that, these patients are really at risk of tracheal stenosis. So I mean, this sort of floppy wall here, because the trachea has been pulled, is sort of flopping around all over the place, and if that gets really narrow, then these patients are really at risk of becoming really profoundly dyspneic and dying. So it's really important to know what this looks like and how to diagnose it. So yeah, this is pretty typical. So these sort of cases, typically they occur just in front of the carina, so about 5 centimeters. You get this formation of a pseudo airway, and I think a lot of these patients these days will probably get a CT, and I can't take credit for this diagnosis because the tracheal avulsion was diagnosed by the radiology team down at the RVC where this cat was referred. But as I say, it's not something that I've seen very much of, so I thought I would share with you guys. So this is typical. So tracheal avulsion results from a rapid increase in intracranial pressure and hyperextension of the neck. Tends to occur just cranial to the carina. The wall remains intact, so the tracheal wall and the cartilage is kind of stretched, creating this sort of pseudo airway. It's a gas-filled, thin-walled, irregularly shaped diverticulum. Yeah, interestingly, you don't often see pneumomediastinum or pneumothorax with these sorts of injuries. And I mean, I'm not convinced this is pneumothorax. I think that is a bit of luck. And I absolutely agree with your description and your conclusions regarding the rest of the pulmonary parenchyma. I think it's probably all hemorrhage and pulmonary contusions. There is a question mark over whether there's a pneumomediastinum here. We can see the dorsal and the ventral wall of the trachea. I can't really convince myself I can make out the major vessels here, so I can't see the brachycephalic trunk or the left subclavian. Could it be there's a bunch of hemorrhage in the mediastinum that's obscuring it? Possibly. But the main thing is that this structure, the spherical, gas-filled, thin-walled structure, just cranial to the carina, that is a pseudo airway caused by a tracheal avulsion, and that's what it looks like. So certainly I learned something from this case, and hopefully you guys now, having seen one, if you see another one, you'll know exactly what it is, and it is something to be very concerned about, like I say, because these cats can very easily obstruct, because these regions of pseudo airway can become very stenotic and prevent them from breathing and oxygenating. They can die as a result. I agree, it's the megaesophagus here as well, probably as a result of the dyspnea and a bit of aerophagia. So yeah, good job. Absolutely nailed to the wall. Fabulous, fabulous job. So any questions about case number 3? So this is a funky one. If not, we can move on to our final case of the evening, which is a 12-year-old female ute of domestic short hair that is anorexic. So we've got 2 radiographs, I believe. We've got a left lateral, and we've got, I think that might be a VD. So who fancies doing case number 4? And all of those guys who've already presented a case are pretty much off hook.
I can do it.
Oh, we've got several people wanting to do case number 4. It's a popular one. I don't mind. I'm very happy if any of you guys.
I normally present, so I'm happy for the other girl to go ahead.
Okay, no worries. Okay.
Okay, so it's a lateral view of a skeletally mature cat. We have severe elevation of the trachea, and we have obliteration of the cardiac silhouette, and we have a radio-opaque structure starting from about the first rib right through to the 1, 2, 3, 4, 5, 6, 7, 8, 9, about the 9th, 10th rib. Yeah, and in that opacity, there is a sort of more radiolucent fissure extending from about the 3rd rib to the 5th rib, and then it sort of seems to kind of split. Looking at the rest of the X-ray, we've got some spondylosis of the vertebrae at around T12, 13, which would indicate possibly that this is an older cat. And in the proximal abdomen, the liver appears to extend beyond the rib cage, and we can see intestine. It's difficult to see. There's possibly an opacity behind the liver, just pushing the small intestine up slightly, but I wouldn't really want to commit to that without seeing a proper abdominal X-ray. So our main concern probably from this X-ray would be the opacity, which is obscuring the cardiac silhouette. And possible causes would be fluid or soft tissue mass. On the DV, slightly off center.
It is, yeah. It's a bit
yeah, but the opacity appears to be taking up both sides of the thorax. And again, it's extending on this view, pretty far caudally to the diaphragm, although we can on each side see some radiolucent, which is most likely inflated lung, but it's really far caudal from about, the rib number 11, I would say, to rib 13 approximately on both sides. That's as much as I can say.
Yeah, no, good job. So nice description. So what would be your conclusions? What do you think is going on here?
Well, differentials would be a tumor, or something in the pericardial sac, but it's much bigger. I've seen pericardial effusions and I've seen diaphragmatic, pericardial peritoneal diaphragmatic hernias. They're not normally, and the ones I've seen have not been as dramatic as this, but I guess that's still a possibility, and that would maybe explain some of the fissures that we've got, because it could be organs within there, possibly. I'm trying to look at the organs in the so again, the ones I've seen, the organs in the abdomen have been affected, and there's been lack of small intestine because it's been basically, it's in the pericardial sac. Now, absolutely. I can't really see or confirm definitely that the small intestine's moved into there, but I guess stomach could have moved. Just to see if I can see the stomach. So I guess stomach could be in there. That's a possibility. Yeah, so I'd say most likely differentials would be either, I think it's less likely to be pericardial, I can't get the word, pleural effusion, that's it. Yeah. I don't think it's less likely to be pleural effusion because of, we've got that piece of, lung space there. But I think some sort of pericardial disease or tumour would maybe be most likely.
Yeah, no, I absolutely agree. So you're absolutely right. There is effacement of the borders of the cardiac silhouette here, and that is absolutely something we'd expect to see with a pleural effusion. But we'd also expect to see some fissure lines and some more convincing retraction of the pulmonary parenchyma from the thoracic wall. And we're not really seeing that in either of these views. What we're seeing is just this giant uniform soft tissue opacity that is kind of filling that ventral thorax, really, right the way down from the cranial thorax to the caudal thorax. And we've also got really marked dorsal displacement of the trachea here as well, and that's not really something that we expect to see just with a pleural effusion. The fact that trachea is so dorsally displaced would sort of suggest there's something space occupying here that's pushing that up. And again, on the DV view, we're not really seeing any fissure lines. We've also got kind of two sort of lobules here of whatever this thing is, and it's all very uniformly soft tissue opaque, and it's really tricky to work out, well, where's the cardiac silhouette here? Is this the heart, or is this the heart? I suspect that's probably the heart in this view, and that's probably the heart in this view. So yeah, there's a suspicion that there's something going on. Whatever it is, it's big and it's soft tissue opaque, and it's in the ventral thorax. In terms of other things like a peritoneal pericardial diaphragmatic hernia, or maybe a diaphragmatic rupture, and we can see that the margins of the diaphragm pretty clearly in the dorsocaudal thorax and then the mid-thorax. They're less clear ventrally because we've just got soft tissue opaque structures up against soft tissue opaque structures. So we've got liver here and whatever this is here, which is this soft tissue opaque. So we've got some effacement of the margins here. But most of the cranial abdominal organs look like they're where they should be. So we can see the liver here. We've got intestines that are pretty much in the mid-abdomen. I agree that we can't really see exactly where the stomach is, but it's probably here. That structure here that you described in the ventral mid-abdomen, that's probably the spleen. So for the most part, these abdominal structures, these cranial abdominal structures, are kind of where they should be, and for the most part we can see the diaphragmatic margins. So something like a diaphragmatic rupture or a PPDH is probably less likely. But we have got this giant soft tissue opaque structure in the ventral thorax. So what I'd like you guys to do now, based on the discussions that we've had, is to sort of tell me where you think this mass is coming from. We've got this soft tissue opaque structure. It's in the ventral thorax. We think we've identified the cardiac silhouette in both the lateral and the orthogonal view. And now we need to decide, okay, we're reasonably happy that this is a mass. Is it going to be pulmonary? Is it going to be mediastinal? Is it going to be from the pericardium? Is it something else? Is it going to be from the extrathoracic structures? Where do we think that this thing, whatever it is coming from? We'll see what you think. And hopefully, Paul everywhere will sync up this time, because it let me down. Case number 3. All right, let's sync this up. See what sort of responses we get. Worked, fabulous. Okay, so wow, split right down the middle. So half of you guys think pulmonary, half of you guys think mediastinal. Okay, so let's go back to the radiographs. So the really kind of hard thing here, I think, is trying to, once we've reached a point where we're confident that this is more likely to be a soft tissue mass rather than a pleural effusion, working out, well, can we actually see the cardiac silhouette? Because if we can identify the cardiac silhouette, then if this is a mediastinal mass, then we'd expect there to be quite marked displacement of the cardiac silhouette. So in the lateral view, you'd expect the cardiac silhouette to be pushed caudally, and then in this abdominal view, we'd expect the cardiac silhouette to be pushed to the opposite side of wherever this mass is. So we expect it to be some mediastinal shift. So I think this is the cardiac silhouette here, and I think it is displaced caudally, and I think it is displaced dorsally as well. And for the cardiac silhouette to be displaced dorsally and caudally to that extent, we should be leaning towards this being a mediastinal mass, because a pulmonary mass wouldn't really do that. It would be very rare to get that degree of displacement of the heart for a pulmonary mass. And here, I think this is probably the cardiac silhouette here. So for mediastinal masses, in my experience, that they tend to be more left-sided than right-sided. So a lot of the structures that are in the mediastinum, the cranial mediastinal lymph nodes, and the thymus or the residual thymic tissues, they just sort of tend to be a little bit more on the left rather than on the right. And I think this is the mass here. And I think this is the cardiac silhouette. So we've got this really profound mediastinal shift and displacement of the cardiac silhouette to the right. And we've already mentioned why we think it's less likely that it's a pleural effusion. We're not really seeing any of the sort of changes that we'd expect to see with a pleural effusion. So fissure lines, retraction of the pulmonary parenchyma from the thoracic wall. And again, we're pretty happy that this diaphragm is intact. So for me, it's most likely to be a giant mediastinal mass. And what we can do, just very quickly, because I'm running over slightly, is just have a quick look at this patient's CT. So this is a 1.25 post-contrast soft tissue reconstruction of this cat's thorax. So we can just run through this and just have a quick gander at what it looks like on a CT. So immediately we're starting to see the mass here. So this is already mass. This is all mass. Again, it's a little bit more left-sided. It's partially mineralized. We're starting to see some of the greater vessels here. And all of the lung is just massively squished up dorsally. And then this is the cardiac silhouette here. So on the right, so it's pushed caudally, it's pushed over to the right, it's pushed dorsally. We've got a tiny wee bit of lung just left in the cranial and the mid-thorax. And then this cat is doing all its breathing really through its caudal lobes. So this giant mediastinal mass. So given that we now know it's a mediastinal mass, we can start thinking about differentials. So mediastinal masses, ones like this that are this humongous, something like a thymoma, I think would be top of the differentialist. So thymomas can get absolutely giant. Other differentials would be, say, lymphoma. So we can't say definitively that this isn't a bunch of giant cranial mediastinal lymph nodes that have all squashed up together. Other things that you can get in the cranial in the mediastinum and the cranial mediastinum, you can get ectopic thyroid carcinomas. So you can get abnormal thyroidal tissue that becomes neoplastic, and you get these ectopic thyroid carcinomas in the cranial mediastinum. Not in this cat, but it's worth mentioning, particularly if you guys spend more time looking at radiographs, is elderly cats can sometimes get just benign mediastinal cysts as well. So if you have an elderly cat that you think has a small cranial mediastinal mass, always worth just popping the probe on. If you find that it's fluid filled, it could just be a benign mediastinal cyst. This cat had a thymoma. So this is a thymoma. Unfortunately, I don't have any surgical pictures to show you because this patient never got as far as theatre, but very easy to sample this using ultrasound. So I mean, really, you stick the probe anywhere on this cat's ventral thorax, and you're going to find the mass. And it's just a case of popping a needle in there, jiggling it about a bit, and then making some good smears to give the pathologist the best possible opportunity of making a definitive diagnosis, which they did for us, and they were very confident that this was a giant thymoma. So yeah, good job. So that was the final case of the evening. So any of you guys have any questions about any of tonight's cases? And apologies for running over ever so slightly. everybody happy with all of the cases? So we had, what do we have? We had big intra-abdominal lipoma, we had linear foreign body in a cat, we had tracheal avulsion, and we had giant mediastinal mass that turned out to be a thymoma. Okay, well, if you guys are all happy, then I believe that's probably us for another month or so. So I hope you enjoyed the cases this evening. Hopefully you can take away a few little hints and tips and tricks for diagnosing these sorts of things. And yeah, I hope I'll see all of you guys again next month for June's film reading. So yeah, enjoy the rest of your evening.